the delegates today a very fruitful meeting, and I hope to see you all one day soon. Now, let me begin. Today I'm going to speak about how to win against colorectal cancer, and the focus of my talk will be on how to screen and what are the risk factors that we can try to avoid to combat against this disease. Now, just as a reminder to all of you, the colon is situated in the abdomen. It is this green organ over here, and it begins with the area of the cecum, which is near the appendix, and ends at the rectum and anus. And it really is the continuity of the small bowel. Now, if you enlarge it, you can see that the the large intestine is very long. It may reach about 6 feet, but of course the length really depends on many factors, including height of the individual, whether the patient is a lady or a man. Obviously there will be some differences. Now, the end of the colon is the area called the rectum. And this is a very important organ. Now, for all intents and purposes, colorectal surgeons like to separate two organs because how we manage these diseases are different, and the patients may also present differently. So this is how the bowel looks like once we've removed them. Now, a little bit about statistics, and just to show you how extensive the problem of colorectal cancer is. In Malaysia, colorectal cancer is the #1 cancer among men, and it is the second most common among women, second only to breast cancer. And what this graph shows is that this disease is primarily still a disease of the elderly. Having said that, statistics have shown that colorectal cancer is increasingly higher now in younger people. Now, we don't really know why. In my own experience, I have been seeing patients a lot in their 40s and 50s. The youngest I've ever seen is in the teens or 20s. So what used to be an increased incidence up to the age of 60 is now changing. And interestingly, what this shows is that the more developed a country is, the higher the rate of colorectal cancer is. So if you go to countries who are less developed, like Bangladesh or Myanmar perhaps, then colorectal cancer is less. But if you go to the Western countries, you see that the colorectal cancer is high. Of course, some may argue that in the more developed countries, we screen these patients more, but nevertheless, what is known is that an individual who previously lived in, say, India, or a group of people who come from India, but when they migrate to, say, Australia or the US, they realize that the Indians in Australia and the US develop more colorectal cancer than those who have stayed back in India. So there is some relation to where these people are, and it is related to how affluent or how wealthy the society is. And perhaps how affluent or how wealthy a society is has to do a lot with the correlation with stress and lifestyle and diet. We'll go into that a little bit more later. Now, in Malaysia, the incidence of colorectal cancer, as I mentioned, is high. In fact, 1 in every 56 men will get colorectal cancer. So you put 56 men in the room, 1 will have the risk of developing colorectal cancer, and in ladies, it's 1 in 74. Now, there is a racial difference. Now, of course, the highest incidence of colorectal cancer is among Chinese men, which is 1 in 39, and in females, 1 in 49. This shows how high the incidence of colorectal cancer is in Malaysia. And I think since there is a wide majority of our audience here in this room who are from the allied health care professionals. So maybe it's a little, so I'll spend a little bit more time on speaking about what the risk factors are. Now, what we know is that by eating a diet higher in red meat and processed meat contributes significantly to the incidence of colorectal cancer. The study shows that if you eat 100 grams of red meat, the increased risk of developing colorectal cancer is 12%. And the reasons why, there's a lot of it is still in study, but there are elements within red meat like nitrous compounds, hemes, polycyclic aromatic hydrocarbons, which directly contributes to tumorigenesis. Now, processed meat is also similar. Processed meat contains a lot of sulfur, amino acids, and this contributes to the development of cancer cells. In fact, every 100 grams of processed meat really increases the risk of colorectal cancer by 16%. And as we all know, Malaysian food is full of fat, and it is shown, though the studies have not significantly concluded that there is a association with obesity and colorectal cancer. But what is shown is that with increasingly obese patients, fat causes and alterations in GI immunity and the inflammatory factors lead to tumorigenesis. And somehow or other, the change in gut microbiome plays a big role in this. Now, the one thing that has been shown is that eating fiber reduces colorectal cancer rates. 10 grams of fiber reduces the rate of colorectal cancer by 10%. Now, why this happens? It is postulated that when we eat fiber, stools are softer, easier to pass through, less contact time with the intestinal mucosa, and therefore less stress on the intestinal mucosa, leading to a less risk of molecular and cellular change, which eventually would lead to colorectal cancer. Right? So we know that high fiber foods, especially cereal fibers and whole grains more than vegetables and fruits, significantly reduces the rates of colorectal cancer. And similarly, vegetables, particularly green vegetables, have anti-carcinogenic compounds like what is listed here, and it contributes to reducing colorectal cancer. There's also research and association that dairy, calcium, and vitamin D increases the risk of colorectal cancer. You can see here, if you take 400 grams of dairy per day, it reduces the risk of cancer by 3%. Similarly, in dietary calcium and vitamin D. Now, I think like any other cancers, excessive alcohol and smoking contributes to cancer, and similarly, that also happens in colorectal cancer. Now, I think this is a very important thing. Exercise and colorectal cancer. Now, exercise, as we all know, is good for our health, no doubt about that. But it has been shown that it actually reduces the progression of cancer, and exercise causes a lot of hormones and anti-inflammatory mediators to be produced, and all this work hand in hand to reduce the incidence of colorectal cancer by up to 30%. Now, it's not only about reducing the rate of colorectal cancer, but exercise has been shown that in patients who have colorectal cancer, if they undergo increased physical activity and exercise, it has been shown to increase overall survival and reduce recurrence, especially in patients who undergo chemotherapy after surgery. Now, when you talk about colorectal cancer, you always talk about what are the stages, like any other cancer, and it all starts with a polyp So with time, this polyp will increase, and if you don't detect it early, it grows bigger. And when it invades the wall, then it becomes a stage 2. Now there are lymph nodes around the colon, and if these lymph nodes are affected, it becomes a stage 3. And if this tumor spreads mainly to the lung and liver, or could be anywhere else, then it becomes a stage 4. And we want to catch it when it's early, because, sorry, this is a picture of how cancer looks like when we perform a colonoscopy, and this is how cancer looks like when we remove it. And you can see on the right here is when the tumor is a polypoidal or truncating mass, and on the left is when the tumor is a constricting mass and can cause intestinal obstruction. Now, I will talk about stages earlier, and unfortunately, because of the lack of screening program, 2/3 of our cancers present late, either in stage 3 or stage 4, and that's not good, because when you all know that the later the stage, the lower the survival, and you can see that if the cancer is detected early, 5-year survivals are more than 80%. So that is a challenge for us who manage colorectal cancer, which is how to increase awareness about it. Now, I think to just quickly go through the symptoms of colorectal cancer. Bleeding is something that's very scary, and in a way it's also a blessing, because anybody who bleeds will present to a doctor, and chances are that doctor will then advise you to see either a gastroenterologist or a surgeon to get it checked. However, more subtle symptoms like mucus discharge or unexplained weight loss will make the patient present a little bit later, and therefore if you have mucus discharge or unexplained weight loss, you should definitely see a doctor. Now, sometimes this weight loss may not be very obvious. You may look in the mirror. You look in the mirror every day and you don't know whether you've lost weight or not, but some of your friends have not seen you over an extended period of time, or if you realize that your clothes don't fit, then that maybe that is a sign of weight loss, right? Of course, if you wait long enough, as I've shown earlier, if the tumor obstructs, then the patient can get abdominal bloatedness and vomiting, and this is how it looks like. The bowel is like a balloon and it can dilate, and if you wait for it long enough, it can even lead to bowel perforation, which can be life-threatening. So these are the presentations that are very remarkable in patients who come to you earlier. Now, this is the most important of symptoms that I'd like to remind all of you all here. Changes in bowel habits. Now, nobody likes to speak about their bowel habits. Even to your spouse or to your parents, nobody really likes to talk about it because we're shy, right? But I think what's important is that we realize, or we have to establish what is normal for ourselves, because you can't really compare it to other family members or to your friends. So some people go once a day, some people go 3 times a day, some people go once every 2 or 3 days, and that may be normal for them because they've been doing it for many, many years. However, if there's any change, as in more frequent, less frequent, more hard, or more diarrhea-like stools, and anything that's more than 2 weeks, you should definitely get it checked. Of course, sometimes you go traveling, there's food poisoning, you eat something wrong, you get diarrhea, or even bloody stools. But if anything that is bothering you for more than 2 weeks, then you should get it checked, right? Now, in terms of treatment of colon cancer, what's important to establish is that, as I mentioned about the lymph nodes, when we remove the bowel, we remove the bowel that is affected, right? We don't need to remove everything unless there's cancer everywhere along the colon. Now, if the cancer is on the right side, we remove on the right side of the colon in a surgery called a right hemicolectomy together with the lymph nodes. And if the tumor is on the left side, with either the transverse colon or descending colon, then we do a left hemicolectomy. And if the tumor involves a sigmoid colon or rectum, then we do something called an anterior resection. Okay. Now, there are many ways we can do this. We can either do traditionally in open surgery, or nowadays we do keyhole or laparoscopic or even robotic surgery. Now, what that means is in the traditional open surgery, you do a big cut like that, and then you remove the bowel, and the patient will have a huge wound. The patient will stay in about 2 weeks. And nowadays, this is rarely done, at least by me, unless it's an emergency situation. Nowadays, we do it keyhole or laparoscopic, where the holes are small, and compared to what is a huge wound, it may not look very significant, but it does result in less pain, faster recovery, and the patient stay about 5 to 7 days in the ward. Nowadays, I personally do a lot of robotic surgery, where it's not just a tool for the surgeon, but it also has significant differences in terms of recovery and patient stay, and less pain and less opioid use, and my patients generally stay 3 to 4 days after major bowel surgery if I were to use a robot. So this is technology, small holes, and it looks like something from a science fiction movie, but we now use this robot, which is controlled by the doctor. Now, don't get me wrong, these are not robots that work autonomously, but it does help with working in the really tight spaces in the pelvis especially. Okay, now if there's a cancer in the lower rectum, then we may not even need to remove the whole rectum, especially if the cancer is small, and we can do this transanal surgeries with no scars at all. Of course, any cancer that's diagnosed would need a CT scan, and sometimes even an MRI, okay, because we need to see exactly where the tumor is, what organs are nearby it, so that we can remove it safely. Sometimes we even may need to do a PET CT scan. Now, chemotherapies are mainly for stage 3 and 4 cancers, and that's why it's important if we catch them early, then the patient may not even need chemotherapy. And radiotherapy is mainly for rectal cancer. So you can see here that most of our cancers present late, either in stage 3 and stage 4. And as I mentioned earlier, the challenge is to catch it early. So how do we do that? Well, I think it comes to the word screening. Now, screening is really a must. In more developed countries, there are compulsory screening for everybody who has reached the age of 50. Now they're even going lower to 45. But you need to screen to prevent colorectal cancer. Now in Malaysia, we are unable to do a nationwide screening program because of cost. To do a colonoscopy would be too expensive to scope 30 million people. So we have something called opportunistic screening, where if a patient were to come to the hospital for whatever other reasons, then the doctor should be able to advise the patient to undergo a colonoscopy. If the patient doesn't want to do a colonoscopy, there are other options, like here, I've listed here, stool test. Now, stool test works on the pretext that if there is a tumor or a polyp, then that will cause some microscopic or very minute bleeding, which may not be which may not be visible to the naked eye. And therefore, when you do a stool test, it's very similar like doing a urine pregnancy test. If you have 2 bars, then you know there's blood. And what happens then is that if it's positive, the patient will need to undergo a colonoscopy, right? Stool DNA tests are very similar to fecal occult blood tests. They actually look for tumor DNA, but they're very expensive. They cost about 800 to 900 ringgit, whereas a fecal occult blood test may cost only about 30, 40 ringgit. So they're not widely available. Flexible sigmoidoscopy is basically a shorter colonoscopy, so you don't need to examine the rest of the colon. And the reason for doing this is because 70% of our colon cancers are on the left side, in the sigmoid colon and rectum. Now, I think this is not an adequate form of screening, but you may want to do it in a younger individual whose symptoms are not alarming. For example, painless, right, fresh blood while passing motion, which may which sounds clinically like a hemorrhoids in a very young individual and who may not want to do a full colonoscopy, then a flexible sigmoidoscopy may be allowed. All right, and the CT colonography, again, is not widely available, but if you see something at the end of the day, you need colonoscopy. So colonoscopy is still the gold standard, right? Now, what does a colonoscopy entail? Basically, the patient is lying on his side, and the scope is inserted through the anus, and it travels along the length of the colon and reaches the appendix, right? And then it may enter into the terminal ileum, which is the last part of the small bowel. And the whole purpose of this is so that we can find polyps or tumors, and this is how a tumor would look like. Okay, and if the polyps or growth are small, they can be removed during the procedure, but if they're too big, then we just biopsy them and then we wait for the pathology report. So this is how tumors begin. They don't suddenly happen overnight. They happen over years. The theory is it takes about 3 to 5 years for a cancer to develop, and it always starts with a small polyp like this, and then it grows bigger. So it takes about 3 to 5 years. So as I mentioned, if they are small, we remove them, and that's the whole purpose of why we do screening. It's not only to look for a polyp, but we can also remove them. Now, I think if there's one slide that everybody needs to remember at the end of this talk is this slide, okay? Now, if you are less than 50 years old, and you have no symptoms and no family history, you are considered low risk and you do not need any screening. But once you reach 50 years old, whether you have symptoms or not, whether you have any family history or not, because colorectal cancer is so prevalent, these patients need to go screening. So how do you screen? Well, at age 50, you do a colonoscopy. And if that's normal, you can do it every 10 years. If not, you do a yearly blood stool test, which can be bought from the clinic or from the pharmacy. Now, if that stool test is positive, you still need to undergo colonoscopy. Now, if you have a family history, which means either one family member who's a first-degree relative, which means father, mother, siblings, children, if they have colorectal cancer, then you're already considered moderate or high risk. All right? Even though you don't have any symptoms, which means you need to do a colonoscopy every 5 years instead of 10. And if the age of that family member who got cancer is younger than 50, for example, let's say he got it at 50 or 45, then don't wait till you're 50 to do it. You've got to do it 10 years earlier. So if they got it at 50, you probably need to do the scope at 40. And if that is normal, you do it every 3 to 5 years. Don't wait every 10 years, right? Now, what is the take-home message from today's talk? Number one, I have shown you that the incidence of colorectal cancer is high in Malaysia. It is the number 1 cancer in men and number 2 in women, and it's becoming increasingly more common in a younger age group. And because of the lack of a screening program, 2/3 of our colorectal cancers present late, stage 3 and stage 4. And therefore, what I've mentioned, early symptom recognition is important. Changes in bowel habits, rectal bleeding, right? Mucus in the stool, all these symptoms should be recognized, and the person seeks medical help as fast as he can. Now, I have listed for you the risk factors like reduced fiber intake, increased red meat and processed food, and overall a sedentary lifestyle contributes to colorectal cancer. Now, screening is a must, and I can't emphasize that more. If you haven't done it, you should do it. If you don't want to do a colonoscopy, which is the gold standard, do a stool test. And I've also showed you that treatment, unfortunately, is surgery. And if you present late, then chemotherapy, radiotherapy. So thank you very much, and thank you to all of you. Once again, I'm sorry I couldn't be there, and I hope you all have a good meeting. Thank you.